my name is Lecia Sequist, and I am an oncologist. My clinical area is lung cancer, and I work at Mass General Hospital and Harvard Medical School in Boston. And I've been a lung cancer focused oncologist for almost 20 years now. In the beginning of my career, I did a lot of drug development and clinical trials looking for better ways to treat our patients with advanced lung cancer. And um, it's been an exciting era in oncology when there's been more targeted therapies and just a lot more different approaches for treating patients with cancer. But after several years of working on that vein and, especially taking care of patients, unfortunately losing a lot of patients to lung cancer, I really wanted to try and focus on early detection because our best chance of curing lung cancer, like most cancers, is if we can find it early before it has spread and it can be surgically removed. But we have a very hard time finding lung cancer at early stages. It usually doesn't have symptoms, or the symptoms are very mild, like a cough, which, could be anything, could be allergies, could be an infection, could be postnasal drip. So it is really hard for people to, both patients and physicians, to detect lung cancer at the earliest stages. So we need better technologies and better methods. And that's what I started focusing my research on about 5 years ago, and have really enjoyed the ability to meet lots of new people. Early detection is a very multidisciplinary field. So, you have different types of medical people working in that field. You've got radiologists, and you've got surgeons, and pulmonologists, and then there's also a lot of other people outside of traditional medical fields that are interested in early detection. So engineers or diagnostics companies. It's a really exciting space, and I've enjoyed that switch in my career, kind of mid-career switch, very much. And that switch in my focus was what got me kind of in the same room with an engineer from MIT named Regina Barzilay. She's a professor at MIT in computer science and electrical engineering, and really thinks about the process of cancer diagnostics in a different way than a lot of clinicians think about it. And so we got thinking and talking, and built a collaboration and designed this model called Sybil that we're going to talk about today. So Sybil is the name of our model. It's named after the ancient prophetesses who were Sibyls. So it doesn't stand for something. A lot of people wonder if it's an anagram that stands for something, but it's the name of a mythological group of women who were able to see the future. And we picked that name because that's what our algorithm is trying to do. So there's lots and lots of artificial intelligence or AI tools that are coming out, whether it's in healthcare or in other aspects of our lives. And I think in a lot of people's minds, it's all lumped together. It's AI. But one thing that I've learned is that AI is such a general term. It could mean almost anything. It's basically using smarter tools, using computer powers, to do tasks that humans can't do or take a really long time to do, and the computer can help you do it faster. So, we've all benefited in our daily lives from having computers help us do things, whether it's searching for information on the internet, or navigating to figure out how to get to someone's house. It's that type of assistance that we're looking for in medicine too, to help doctors and other healthcare providers do their job easier, quicker, smarter, not necessarily take the place of clinicians, but just a tool to help us do our jobs better. And when it comes to radiology, any kind of imaging, whether it's an X-ray, like a mammogram, or whether it's a three-dimensional image like a CAT scan or an MRI, in medicine, we have traditionally used radiology imaging to tell us what's happening with a patient right now. Is there a mass? Is there a tumor? Is there, a trauma? Is there a broken bone? Is there COVID right now versus not? Is there a stroke? We always used it to tell us what's going on with the patient at that moment. And what Sybil and some other tools similar to it are trying to do is not necessarily use those images to tell you what's happening today with the patient, but to be able to look to the future and say, what is this patient at risk for? That's what's really different about the research we published, is that we're using a CAT scan that's taken today on a patient, but we're not necessarily looking for a cancer that's present or visible on that scan. What we're looking for is the background pattern of risk that is imaged with a CAT scan to tell us, is this patient in a high risk category or a low risk category? And that's just by pattern recognition. That's a lot of us are very familiar with AI, even if we don't know it's called AI, when we're searching on the internet. And, whatever search engine you use, they all have AI algorithms. So that if you type in just one word out of a 4-word thing that you're thinking of, the computer seems to like very magically fill in the other words for you, right? Sometimes it's almost, you wonder, how did it know that's what I was going to type in? But it's pattern recognition, and it's it's predicting the future, what you're going to type based on information that it knows from thousands of other people who have typed similar things, or maybe have your demographics, or have had run similar searches to what you've run in the past. It kind of knows what you might search for in the future. That's kind of what we're doing here. Is we've trained Sybil to look at we've trained Sybil with thousands and thousands of CAT scans of patients' chests and lungs. And we've told the model, this person ended up getting cancer 4 years later. This person never ended up getting cancer. This person got cancer 6 months later. And so the computer has learned to recognize the patterns, not in the same way that a human looks at a CAT scan. When a human radiologist looks at a CAT scan, they have a very systematic way of looking at it. And they look at the right lung, and they look at the left lung, they look at the lymph nodes and the heart and the bones so that they don't miss anything. But it's all anatomy based. Our eyes and our brains can't necessarily see the type of underlying patterns in the data that a computer can pick out. It's just not the way we've been trained, or even necessarily the way that we interpret visual images. What Sybil is doing is using all of the information contained in the digital image, and it's looking for pattern recognition where it's been trained to see cancer, or to see the patterns that are affiliated with cancer before the cancer develops. And so Sybil can say, these scans are high risk and these other patients are low risk for developing lung cancer. But right now we've designed it to look 6 years out in the future and tell us, what is this person's risk of lung cancer? It's not giving a diagnosis, but it's risk stratifying people. And that's what preventive medicine is all about. We have traditionally, we know that high blood pressure is a risk factor for having heart attacks. So we screen people in their primary care doctor's office for high blood pressure. And if they have high blood pressure, we try and lower it with medicines, or we recommend things like exercise or weight loss. And all of these things are to decrease that person's risk of a future health problem. And, a lot of preventive medicine has to do with risk reduction. How can we decrease your risk for certain diseases to happen in the future? With a lot of diseases, though, we don't necessarily know what to screen for. And the same is really true with cancer. What cancer screening has, for the most part, been about, can we see a cancer? When you get a mammogram done on your breast, they're looking for a cancer that's visible. When you get a chest CT for lung cancer screening, same thing, we're looking for a visible cancer. If we can take a step back in time and even try to identify those patients who are at the highest risk before a cancer is even visible, and we monitor those patients closely, we have a better chance of being able to pick up the cancer when it first appears and treat it and get rid of it at its earliest stages. Well, that's what we're doing clinical trials now to determine. So, lung cancer screening is available, not necessarily with the Sybil AI tool, but with standard CAT scans. It's available today, and most people who could qualify are not taking advantage of it for a lot of complicated reasons. But in order to qualify, currently, you have to be at least 50 years old and you have to have smoked cigarettes in the past or still today, kind of a decent amount. The threshold is fairly high of tobacco history that's required to even get your foot in the door for screening. And sadly, in the US, although there's over 10 million people that are eligible for lung cancer screening, only 5 to 10% of them are actually getting it. So for a variety of reasons that have to do with hospitals offering it, to doctors ordering it, to patients knowing about it or wanting it, it's a complicated issue, but we're not screening hardly anybody for lung cancer, unfortunately. At the same time, the disease is changing. What I see in my clinic as an oncologist, seeing people who are already diagnosed with lung cancer, we see people all the time who would not have qualified for lung cancer screening, even if they wanted to get it. They're younger than 50. They've smoked a lower amount than the threshold, or even never smokers are getting lung cancer now at an increasingly common rate. We think this has to do probably with air pollution and other types of environmental exposures, but lung cancer in people who've never smoked is on the rise quickly. So we have to change who we're letting in the door for lung cancer screening, and we have to throw those doors open wide. The same time, it doesn't make sense to screen every living person for lung cancer, because that's just way too many CAT scans. There's costs and risk associated with screening people who are not at high risk. We have to develop tools to figure out who is at risk and should be screened and who's not and maybe doesn't need screening. That's where we hope Sybil can really fit in. But we're doing clinical trials to prove that now. We're running a series of trials along with collaborators around the world to figure out how can Sybil help real patients. It's not something that's covered by insurance right now, but it's not something that I would recommend for the general public right now either. We're doing clinical trials to figure out how best to use it and what kind of information is actionable or not actionable. So it's still in the experimental phase, but ultimately tools like this, I think the question of cost or who's going to pay for it, it very much depends on how the tool is developed. So there are some computer AI tools that are being developed by companies who, just like drug companies that develop new drugs, they have to recoup the cost of the development by charging for their algorithm. Our algorithm actually is open source. It was developed from an academic collaboration between MIT and Mass General Hospital. And, there's no, it's open source. Anyone can use it essentially for free. So there's not a cost associated with it right now. And we hope that encourages investigators from around the world to use it and study it on their own too, so that we can all move forward together. So I think that within a couple of years, we'll have reports out from these various clinical trials that showed what it could do, what it couldn't do, what its strengths were, and what its weaknesses were. And that's when doctors can start to implement it as a tool that they would use to take care of a patient in front of them. With any computer algorithm, you have to be wary of bias. And that's really important. to our research team as well, that we make sure that this is an algorithm that could be used globally, could be used on people of different ages, different sex, different races. And of course, we've only looked at it in, we've looked at it in a large group of people, but it's not inclusive of all the diversity that's worldwide. So that is one of the main things we're working on right now with our collaborators, is to try to get populations that are representative of different parts of the world, different demographics, and look at, does the algorithm translate just as well, or are adjustments needed to retrain it to include more of a certain type of person. It's really important with any algorithm that you think about those sources of bias. Yeah, that's one of the main downsides with lung cancer screening right now, is that our lungs are very busy places. A lot of stuff comes in and out with every breath. And so you get soot in your lungs, you get viruses in your lungs, you get all kinds of stuff that can cause visual abnormalities in the lungs from either you breathe it in or your body's reacting to what you breathe in. And that's what causes a lot of confusion for doctors today when we're looking at CAT scans and trying to see, is there an early tumor there? We get faked out all the time by a viral infection or some other type of inflammation or a little piece of mucus that's in our lungs. So that's why I think actually looking at future risk is helpful, because it helps us cut through some of the noise that might be visible in a busy place like the lungs, and really look at future risk. But yes, it is possible that the model could also overestimate someone's risk because of some kind of fake out. And that's why none of these things are set in stone. It's a risk, it's not a diagnosis. So, if person A has a 70% chance of lung cancer in the future based on Sybil, and person B has only a 1% risk, it doesn't guarantee that person A is going to get lung cancer, or that person B couldn't. It just tries to stratify you, that someone's at higher risk than someone else, and you might treat them differently if you were taking care of them. You might watch their lungs more carefully, or try to modulate that risk if you could. Even though Sybil isn't quite ready to be rolled out and it's still being studied in the experimental phase of its development, lung cancer screening is available. And I mentioned some of the problems. It's not being ordered on everybody, or you have to be 50 and you have to have smoked the equivalent of at least 1 pack a day for 20 years to get lung cancer screening now. But that is a lot of people who fit into those categories. And so if you're watching and you or someone you love or a friend is a smoker or used to smoke tobacco, please tell them that lung cancer screening is out there. Tell them that they should talk to their doctor about whether they qualify for it, and if they qualify, they should definitely go. Lung cancer screening is a very powerful tool. It's able to save lives by finding cancer early, and lung cancer is on the rise. So it's really important to get screened if you're eligible. And my goal in the future is to open the doors wider so more people could be eligible.